Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
We have Dr. Carlo Poggio as the first presenter today. He's the owner of Studio Associato Poggio, an interdisciplinary dental practice with more than 50 years of history, located in the heart of Milan, a historical center. He's also a visiting professor for interdisciplinary treatments at the postgraduate program in orthodontics in the University of Milan, and an adjunct assistant professor at the Department of Prosthodontics, Eastman Institute of Oral Health, University of Rochester in New York. He's a member of the Cochrane Oral Health Group, Manchester, UK, as well as several national and international dental associations. He's a member of the executive board of the Italian Academy of Prosthetic Dentistry, one of the largest Italian dental societies, and a member of the International Relationship Committee of the American Prosthodontic Society. He has published several articles in peer-reviewed journals, lectured extensively in Italy and abroad on topics related to interdisciplinary treatment planning in dentistry and occlusion, management of TMD patients, metal-free prosthodontics materials, and the use of dental implants in complex interdisciplinary rehabilitation. Dr. Poggio, thank you so much and welcome to Dental Webinar Series.
So thank you, my friend. It's a really honor and a pleasure to join this series of webinar. And I'm happy that we are in the end of this 2020, which has been quite a complex year. And I'm happy also to share with you some of my knowledge and experience about full mouth rehabilitation, something that it's an approach that may be different from other type of prosthodontics treatment. And first of all, I was just willing to say one thing about we are all sharing together this global village. And it's incredible how this year has been changing a lot of the way we used to do. And so I'm really, really happy to have a chance to join people that I could have never joined in maybe the previous years. So that's a great, great moment, even if it's also somehow a dramatic moment in many parts of the world. And what I'm willing to talk in the next 30 minutes is about the one of the things that I believe is missing nowadays in dentistry. And this thing is one word, and the word is diagnosis. I think that we tend to work a lot on topics like tips and tricks, specific techniques to do something. And the focus is all about technical issues. But many, many times there is something that is missing, which is the issue of diagnosis. I give you just an example. In these times, we are talking a lot about what is called minimally invasive dentistry, especially in the Western world. And minimally invasive dentistry may be, for example, doing veneers. And so it's an approach which is considered, generally speaking, minimally invasive. But I want to share I want to shift the attention on something else. What does it mean being non-invasive in 2020 or in 2017, where this picture was taken? You can see that this man is having a lot of wear problems in the upper and in the lower teeth. You can see that in the lower he has less than 30% of the tooth structure, in the upper maybe 50% of tooth structure. So if we think about being non-invasive, like using veneers, we could think that in this patient we can do veneers instead of doing full crowns, or we can even think about doing direct restorations. For example, if we are very skillful, if we are very, very good with our hands, we can think about doing hands-free restorations. But I want to share with you another picture, and this picture is more than 15 years before. And if you look, this is the same gentleman, and if you look carefully, you can see that he has absolutely the same type of tooth wear. And so 13 years have been passing by, and in this patient we haven't been doing anything at all as prosthodontic treatment. The only thing that we have been doing is a bite, a night guard, to protect his nocturnal bruxism. And this night guard has been changed several times because I'm following this patient since 1996, and all we have been doing in this patient is just this. So my point is that it's not that a technique is possible, and so we must do that every time. What is important is that a diagnosis is made, and according to that diagnosis, we can do the most proper type of treatment. So minimally invasive is not doing something like veneers everywhere. Minimally invasive is doing the less amount of therapy that can be required, or more type of treatment, more invasive treatment if it's required by the clinical condition or required by the patient. So this patient is still suffering from ceramic deficiency probably, but it's not obviously a disease. And so the issue of making a good diagnosis before starting a treatment is really, really important. This is another completely different type of case. She is a patient suffering from a serious periodontal disease. And you can see that, for example, the lower incisors almost have no attachment at all and no bone at all. And also in the posterior areas, you can see that the furcation of the molars have what look like serious lesion. And so this patient is a type of patient that can be considered what we call terminal dentition from some time. This was in 2008 when she was proposed to extract all the teeth. And this is in 2010 when she had just scaling and root planing. And you can see that the general periodontal conditions looks much better. This was in 2012. This was in 2016. And as you can see, she still has all the dentition with no problem almost at all. So just inflammation control in this patient allowed us to achieve these results. And even if you look at the occlusion is not ideal. She has a cuspid that is completely in cross, but she's not suffering from anything. So we know that teeth should be protected, and we should always work to try to protect and to keep as long as possible the existing dentition. And this was in 2018, 10 years after the first slides. And as you see, everything is pretty stable, and the patient is just following oral hygiene in a perfect way. So I would consider looking at these two pictures with 10 years of difference in time that we should give teeth a chance every time, because this is something which is absolutely important. And nowadays, many times it's not enough considered. So diagnosis is very, very important. Being minimally invasive is doing the proper thing in the proper patient, and always starting from a periodontal evaluation of the patient before anything else. Then obviously we need to have some knowledge about other things. For example, when we are dealing with more complex treatment, we have to have a knowledge about occlusal issues. This was a systematic review I did with my friend Daniele Manfredini a couple of years ago about how to manage prosthodontic treatment in patients with complex occlusal conditions. And we need to have knowledge also about material issues. This is a systematic review done for Cochrane according to the use of ceramic materials, metal-free materials. And recently with my good friend Carlo E, we have been working also on a systematic review about relationship between prosthesis and periodontal, which is another area which is very, very important. So to perform a complex treatment, we need basically to have knowledge about these three issues, which are the issue of occlusion, the issue of materials, and the issues of the relationship between dental prosthesis and the periodontal. And coming to our topic, full mouth rehabilitation, what we have been doing for many, many years. This is a very old treatment, and this patient came to my office around 20 years ago because she had several issues. She had endodontic problems, she had periodontal problems. She was unhappy with her old prosthesis, and so we went for making a new treatment for her. And this was in 2002, and we redid all the endo treatment. We did also the periodontal surgery to correct also all the defects. And in the end, we took impression, face bows, records, etc. And the dental technician did a wonderful work with metal ceramic. We try in the metal, and then we try in the ceramic. And that was the end of this full mouth rehabilitation. And as you can see, this was in 2002, and this is in 2017, which is 15 years later. And now we are in 2020, which is 18 years later. And as you can see from the X-rays and from the clinical pictures, everything is absolutely very, very stable. And the aesthetic of the patient is something that she is happy with. So this was the past. Then recently, we started a few new things. In 2012, we started trying the first intraoral scanners, and we started with digital impressions. At the time, there were some limitations in this type of workflow, but we could do very nice looking crowns. But more recently, what has been really changing is the union between digital impressions and monolithic materials that can be milled. And putting together this two type of approach, which is monolithic materials that can be milled together with digital impressions, we can treat nowadays with full mouth rehabilitation treatments that are really, really complex. This patient came to my office a few years ago, and he had very severe problems in his mouth, and he was very unhappy with his aesthetics. And you can see that he has a lot of wear everywhere, and you can see that he has several missing teeth. So in the posterior area, a lot of teeth are missing or need to be extracted, and in the anterior, almost every tooth is completely worn off. So he came to office looking for a full mouth rehabilitation because he was willing to solve all the problems of his mouth. And you see in these X-rays that there are molars that need to be extracted because they cannot be treated. There are areas where implants need to be inserted. And generally speaking, if we want to achieve a better looking aesthetics, we need also to rebuild many, many teeth. So how did we manage nowadays a full mouth rehabilitation like this one? First of all, we started with an intraoral scan at the time of first consultation. And exactly at that time, first consultation, we did an intraoral scan with an occlusal relationship, which was a maximum intercuspal position, and the occlusal relationship, which was centric relation recording. And with this second occlusal relationship, we could send to the lab and have the lab make a digital walks-up. Digital walks-up means that we can plan and see what can become the treatment of this patient. And in the meantime, the patient undergoes the extractions, the oral hygiene phase, and he comes back to my dental chair where we can test a mock-up in his mouth to see how is it going to work with this type of treatment. So we have basically a milled mock-up printed on a printed model. And when we apply this milled mock-up with just a little Vaseline in the mouth of the patient, we can give him an idea of what it's going to look like, the treatment. So it's not just digital impressions, the big change. The big change is going to a digital workflow. So we can show to the patient immediately how he's going to look before and after with treatment, something that in the past we could not do with the same simplicity. And digital impressions, in my opinion, are not digital impressions, but they are an intraoral scanner is, first of all, a powerful measurement and analysis tool, which allows us to communicate with the patient and with the dental lab. So in this patient, we decided to do provisional for full crowns in the upper and bonded restorations in the lower. So we have the lab make everything. We prepped the tooth in the upper. We bonded the temporary restorations in the lower. And this was after the preparation, very minimally preparation for full crown. And in the lower, we just bonded the treatment. Here are the preparations after 2 weeks of healing of the soft tissues. And then in the second appointment, we did a preparation for the lower for making veneers. And we took an impression always with a scanner. So the impression that we took in the lower was an impression done with 3D scanning technology. And after we have been doing this, we sent this to the lab, and the lab got what was already prepared in the workshop. So he had just to copy what he had planned in the beginning. And after we cemented the veneers in the lower, we went for upper final impression, and we also had placed some implants where teeth was missing completely. So these are the lab phases for making the final upper crowns and the final lower crowns on implants. And so this is the trying of upper and lower crowns. As you can see here, we have been choosing to do full monolithic restorations, which means that everything we are doing is completely milled. Just the amount of handwork by the lab is very, very limited. And this is in the end of our treatment, what is going to look like. These are full monolithic restorations in the upper done with cubic zirconia, and in the lower we have full monolithic restorations done with lithium disilicate. So this is the way he is looking in the left and right lateral. And this treatment is really interesting because we started from a very poor oral hygiene, a very poor dental tissue conditions. And by working only with full digital workflow, nothing has been done in this patient with analog workflow. And by working only with full monolithic materials, we could achieve a complex treatment. So this is a good example to me of what can be a full mouth, full digital, full monolithic treatment, something that in the past obviously was not possible to manage in the same way. And it's not only doing complex treatment on teeth and implants, it's also doing complex treatment on implants only. For example, this patient had been treated years before with implants that failed, and he came to my office in this condition. In the upper, he was a dentulous, and he had some implants that were failing completely, and one implant was also broken. And so what we have been doing here is exactly what we have been doing in the previous patient. We did our scanning in the first time, in the first consultation, and by doing this, we could send to the dental lab all the information for making a mock-up, something that we use to allow to discuss with the patient a possible treatment. So this was the initial condition in this patient. And this is a mock-up. It's something that has just been developed by the lab, and it's just applied in the upper. There is nothing in keeping this stable. It's just a piece of plastic which is needed to discuss with the patient. And after making our evaluations, we went for doing surgery with a minimally invasive procedure. And during surgery, we realigned our provisional on the implants, on 4 implants, and we waited for healing. And after healing was completely, after 4 months, we went back for making our final impressions. And this is 6 months, I'm sorry, this is the provisional after 6 months. And you can see that we had nice tissue healing. And you can see that these are the 4 implants in the upper. We placed our scan abutment. We went for final impression. And this is absolutely the way we managed to do the work with the dental technician. And this is the final work, the final prosthesis. And you can see that it's a full mouth zirconia rehabilitation. And it's something that is absolutely very, very well integrated in the soft tissues. So this is just an example of a treatment that has been done on full mouth rehabilitation on implants. As the treatment before I show you was a full mouth rehabilitation done with teeth and implants. What is most important, and I'm coming to my end, is that nowadays we have wonderful materials, wonderful technology. What we need to do is to have a proper diagnosis for every type of treatment. Otherwise, we will end up doing a lot of unnecessary treatment and doing something that is not required by our patients. But I think that from the standpoint of our approach to treatment nowadays in prosthodontics, we are living a wonderful age with wonderful materials and wonderful technology. So I took a picture a couple of years ago in London of this monument where it's written, "Our future is greater than our past." This 2020 is not a very easy year, but I'm still thinking that our future is greater than our past. So I'd like to thank you for joining me for these 30 minutes. And I like to thank you really very, very much for having a chance to be together with you.
All right. Thank you. Thank you so much, Dr. Poggio. That has been an eye-opening, these are things that I guess, trying to do this, you're dependent on your good laboratory. Your lab people must be, right there as well. Yes.
Well, the most important thing is that the lab is fully converted into digital workflow, because if the lab is still thinking that he cannot do this and he cannot do that, it's impossible that they do that. Yeah. But if the lab is convinced that he can do whatever he wants, we can do that. I'm now 4 years working only with intraoral scanner, and I would say that I have taken less than 4 or 5 analog impressions in 4 years. Wow. Because all the other type of treatment I've been doing with scanning, and 90% of the workflow, especially when they are single crowns or few units, is also entirely done model free, which is something that makes things really, really, really fast and really, really important, well managed, let's say.
A quick question here. Somebody says, is there any disadvantage of using, digital scanning?
I would say that the most disadvantage that there is if you have a prosthesis, for example, a broken prosthesis, and you need to repair that. That's something that you cannot do with digital impressions, because if you already have a device and you cannot take it out of the mouth of the patient and send to the lab with all the reference to the rest of the mouth. Okay. So that's the only thing that the 4 impressions that I've been doing in these years are in conditions where I needed to repair something that had broken, for example. So like doing a position impression, where we need to send something to the lab with all the reference of the mouth. But most of the times, especially nowadays that we are working almost entirely with monolithic materials or with monolithic zirconia, and we just do veneering on the vestibular surface, there is no limitation to working with a scanner. Okay. That's my own experience, but obviously I'm aware that there may be different evaluation.
Okay. One more question here. They said, have you had any challenges managing a diabetic patient?
Well, in the patient I show you, the lady with severe periodontal problems, she was not diabetic, but many times I've been managing from periodontal standpoint patients with diabetes, and obviously in a patient with diabetes you need to have a perfect knowledge of how to manage. You need to interact with the physician, and you need to take care of your patient in a more specific way, because otherwise he's going to lose a lot of his dentition.
Okay. All right. Anyway, thank you so much, Dr. Poggio. Looking forward to having you. Hopefully we can create an opportunity to, share some difficult cases with you. We do have some difficult cases that we are currently working.
I'd be very, very happy. I'm available.
All right.
Healing Hands Health Society presents Dental Webinar Series. we have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hands.org/dental-training. For future inquiries, contact Facilitator